This is Dr. Macon, Singletary, your friendly North Raleigh periodontist. We're going to cover in our episode today is periodontal disease, gum disease, reversible. So there are some things that you will hear that will help you determine, do you have a problem? So hopefully you can listen to it, understand what we're talking about, and if you catch it early enough, you don't have to come and see me. You can do it in the confines of your home. So listen to the podcast and hopefully you'll get some questions answered and it'd be beneficial for you.
Welcome to the Gum Guru, the podcast where we talk about all things gums, implants, and oral health. In each episode, Dr. Macon Singletary of North Raleigh Periodontics shares tips to keep your teeth and gums healthy.
Welcome to the Gum Guru podcast. Thank you so much for being here with us today. I am Jason Kong and I have the pleasure of being here with Dr. Macon Singletary. And today, doctor, we are talking about periodontal disease. And I'm sure you get the question often, is this something that is reversible?
I do, I really do. And by the way, happy spring. This is a question people come in, patients come in and say, you know, I've been told I have periodontal disease. Does this go away? Can you cure it? Is it reversible? So the answer to the question is, first of all, understand what causes it. But early gum disease, gingivitis, is reversible. The etiology of periodontal disease is bacteria. Plaque is a colony of bacteria. When it initially grows, your immune system reacts to it. That inflammatory response is inflammation of the gingiva or gingivitis. You always have an attachment around every tooth that's consistent of about 3 millimeters above bone that makes a cuff. That cuff is 0 to 3 millimeters in depth, and the bacteria will grow around the neck of the tooth, and your immune system, the neutrophils, will react to that. That inflammatory response, the bacteria is engulfed by the neutrophils. They kill the bacteria, split, and the enzymes comes out, destroys everything in the area, gum tissue attachment and bone. But prior to that, those inflammatory mediators cause capillary dilation. So when they say inflammation of the gingiva turns red, the capillaries swell up a little bit, you get a little edema, and so you may notice a little puffiness, a little redness. And you touch the gum or floss or brush, it may bleed a little bit. And I tell patients, you know, some patients, well, it was bleeding, I stopped messing with it because I didn't want to hurt it. No, go after it, because if you get the plaque off, it will heal and it will reverse.
One of the scary things, at least to me as a patient, about our mouths is that oftentimes we'll feel things that are uncomfortable or maybe painful, and then it'll just go away. And that doesn't always mean that it's fixed. And so having an idea of when to see a specialist or when to see you makes a whole lot of sense. So when do we need to get you involved?
Well, you're right. I mean, I tell patients if it hurts, it's like high blood pressure and glaucoma, it's curtains. But yeah, I mean, tenderness, bleeding when you floss and brush is a sign of early gum disease. And if that persists, then it becomes not reversible. Once the gum separates from the root of the tooth, you get bone loss. And if you have thick gum, you're going to get a space between the tooth of the gum deeper than 3 millimeters. You know, somebody got their PhD to figure out what God already knew. The normal space between the tooth of the gum is 0 to 3 millimeters. And when you brush, floss, rinse, whatever you do to clean your teeth, you can clean 0 to 3. But not knowing that these areas exist, you won't feel it. You know, it may not hurt. But if you start getting areas deep in 3 millimeters, what you're doing at home is not going to help. It will help above the gum, but below the gum, deeper than 3 millimeters, it's got to be professionally manipulated.
If we are in those early stages and maybe we are seeing the puffiness or the redness or maybe a little bit of bleeding, and we do start to attack it, how long would it take for someone under those circumstances to resolve it or make it go away?
Yeah, gingivitis, really, if you start working at it in 24 to 72 hours,
wow,
a day to 3 days, being consistent. You know, I tell patients, give it 2 or 3 days, and if it's not better, call me. The patients of record, you know, they may be stable, they may have had bone loss, and you go gingivitis as a diagnosis, and that's the reversible part. Then you got periodontitis, which is inflammation of the gum and bone. And I guess I grew up in Durham, we call it pyorrhea in the old days. here in Raleigh, we're more erudite. We call it periodontal disease or gum disease, gingivitis, periodontitis. It can be early, moderate, or advanced. And to diagnose that will determine what kind of treatment modality is performed for the patient. But the earlier it's caught, the more quicker it's resolved. You don't cure gum disease, you control it. And the reason why you don't cure it is because you have bacteria in your mouth all the time. If you don't have bacteria in your mouth, you're dead. It's rigor mortis. You're supposed to have bacteria there.
Let's say we start feeling these symptoms or seeing them and we don't quite take action immediately. Maybe it's something that we put off. Is there a point at which, I mean, you did tell us when, if we see something and we act and 72 hours later, if we don't see a difference, it's time to call a professional. But if it's something that we continually put off, is there a point where it's not reversible, I guess is my question.
Yes. Once the gum separates from the root of the tooth and you get that bone loss, it may look the same, it may look fine. I have patients come in and they say, well, I brushed the floss and went away. Generally, that's a sign that you ought to come on in anyway, because if you do have thick gum, it's not going to shrink. It will firm up, but you've got a reversible situation where the bone's resorbed and the space between the tooth and the gum will need to be treated. Inflammation will ebb and flow depending on a lot of things, medication, what you eat, stress, habit, clenching and grinding. So those things can accelerate bone loss. You're not aware of it. You could be banging on a tooth and you may say, well, it felt a little high, but I'm eating okay, and there's no pain. Those are all signs that something's not right, and if you ignore it, it will be a problem. Ignorance is not bliss. You want to find out what's going on and treat it earlier. And the earlier you treat it, you're going to maintain more support long term, because it is cumulative. The effect of periodontal disease over time adds up. I can look at an x-ray and 50% of the adult population above the age of 30 has some form of bone loss, 75% above the age of 60. AI, we have it all over the place, in my office, including my brain, but you can't tell active gum disease by looking at an x-ray. You got to look in the mouth. But you can tell past history. And so, yes, you can tell an irreversible situation by looking at an x-ray. And I can look at some patients, they come in and, I've been told I need to see a periodontist, and I try to get information like, well, did you notice it? If they notice it, that's one thing. But if the dentist noticed it, there's another. It tells me something about, maybe the advanced nature or the concern of the patient. Are they aware of things? And I need to help them be more aware of it. But I can look at the x-ray, and I've done this a lot, and some patients like it, some patients don't. I mean, I've had patients come in and they haven't had their teeth cleaned in 30 years. They got plaque and calculus all over the place. They still got their teeth. I call it the pyramid of susceptibility, a small pyramid, high threshold. It takes a lot to be a problem. Some people come in, they have no plaque at all, and they're losing their teeth. Big pyramid, low threshold. But I can look at the x-ray and I say, you look like you're a 40-year-old and they're 60. That's a good sign. They got the mouth of a 40-year-old. Or some people come in and they're 30 years old. I said, you got the mouth of a 60-year-old. They're in trouble. And they've had acute reaction to the bacteria and aggressive, and delaying treatment is not good. You have an irreversible situation, and implants are not the greatest thing since sliced bread. Somebody that loses their teeth due to periodontal disease, they'll lose their implants as well. Even though initially they may heal, if you lose a tooth to periodontal disease, you can lose implants. And you want to catch it early, you want to keep your natural teeth.
Let's talk about the consequences of letting this get advanced, and let's say you do have to go down the road to implants, or maybe before then. What do you feel as a patient when things have gone too far?
Bad breath. Some people notice bad breath. There are 3 reasons for bad breath: sinus, mouth, and stomach. But you may notice bad breath. When they eat, you may notice some sensitivity to hot and cold. In recession, if you have thin gum, you can have healthy gum tissue and have periodontal disease. We call it non-dystrophic gum disease, where somebody's had orthodontic therapy and the teeth have moved out of the bony housing, even though the forces of occlusion are correct and along the long axis and it looks great, but the tooth is out of the bony housing, the gum is thin, and there's a prominent root, and toothbrush abrasion will cause recession. An extra soft brush is what you got to brush with. I tell everybody 4 times a day, floss and brush, extra soft brush. But once that happens, the patient may notice it, and they will say, "Hey, I'm long, and my teeth look long. I got sensitivity to hot and cold." That's another thing. And again, I asked the patient, "Did you notice this, or did the dentist notice this?" But sensitivity to hot and cold, bad breath, mobile teeth. Once the tooth becomes mobile, it doesn't necessarily mean you're going to lose the tooth. It can be due to occlusal trauma, clenching and grinding, and addressing that and addressing the inflammation, it could tighten up. But those are sort of the signs: bleeding, swelling, bad taste, mobility. When you bite down on something, it hurts. Sometimes they'll work at it and take some pain medication or go away, but that's a red flag. When the damage is done, particularly bone loss, even though it may feel better, get it checked out.
Yeah, that's great advice. When we get to that point, of course, we need to see a professional. What types of treatment are we looking at if we've got an advanced case?
Well, I call it my golf bag of treatment options. I'm not a golfer, I'm too uncoordinated. I can do a sailboat. but this golf bag of treatment options, the antibiotic club is a putter. You can get around the course with a putter, but not very effectively. The antibiotic kills the bacteria, and there are about 11 to 12 species of bacteria that's anaerobic, doesn't like oxygen, that are the bad guys. And you got to manipulate them. An antibiotic will kill them, they'll grow back. And so that's the difference between what a dentist does, or general dentist, and what a periodontist does. A general dentist can do a filling and you're done. You do a crown and you're done, pretty much. You come in and see a periodontist, or you brush and floss, you have your teeth clean, take the antibiotic, maybe for 6 to 8 weeks, the antibiotic has some effect, but then the bacteria is growing back. You brush your teeth, within 30 minutes of you brushing your teeth, the bacteria is growing back. So it's an ongoing issue. So in that golf bag of treatment options, it's predicated upon a few things what I use. The medical history, what I see on the x-rays, in my intraoral exam. We start out maybe with an antibiotic if there's a swelling and acute situation where there's exudate or pus. If not, if it's chronic inflammatory gum disease, the 5 iron is the root plane club. It's not surgery, it's deep cleaning. We numb you up to do it. Some people call it root planing with anesthetic. But the key to understand is it is deep cleaning, but we're numbing the person up to do it. You can have a regular cleaning, and they call it deep cleaning, but they're not numbing up. You gotta use some anesthetic to go down on the root. It'll be uncomfortable if you didn't do that. But the whole goal is to get the root clean. Anything greater than 5 millimeters between the tooth and the gum, ability to do that starts to go down. We can disrupt the live bacteria all the way down, but the dead bacteria, the calculus, that's the cell wall of the bacteria, that's a delayed response, that's a lymphocytic response. When we were root planing, we were doing it by feel. So anything greater than 5 millimeters, our ability to do that effectively starts to go down. That's why the laser protocol, we have the laser new attachment procedure, is good in theory, but flawed in technique, because the laser root plane laser pretty much. Well, it's all by feel. They say it's non-surgical. Well, if you have, they're relying on the laser to do all the work. Well, you're not going to get all the calculus off the root of the tooth when it's deeper than 5 millimeters. There's going to be some toxin there. You got to see it. So I do what we call minimally invasive laser-assisted procedure. That's my Big Bertha. I got more lasers you can stick a stick at. I feel like Luke Skywalker sometimes. But I use a combination, and when I do use that, I'm detoxifying the root. And so in that golf bag, there are other things too, making sure the bite's right. I'd look at medication. I believe in the KISS principle, keep it simple, but there are things that you can do at home above the gum that will help stem the tide. And whatever I do in the office will last longer. But the 2 most important parts of maintaining gum tissue health are the most inexpensive. Floss and brush 4 times a day, That's free. You come here, it's not free. But if you do that and stay in a good maintenance program, whatever we do, whatever club we pull out is going to last longer. And that's the important thing to understand. It's treatable. It's not curable. You control it unless you have gingivitis. And then gingivitis is reversible. But once you lose bone, it's not.
That's good to know that a lot of what we experience is in our hands, and if we have a good routine and good maintenance at home, that we can nip a lot of this in the bud. And so that's excellent to know. Well, Dr. Singletary, we always leave every episode with an action step that we can take on our own. Did we just cover it, or is there a different action step?
Well, I think most importantly is just be aware of, what's going on. We have a lot going on in our lives, and maybe a little bleeding here and there, we ignore it. But if you're having bleeding, get it checked out. Call our office. See your dentist. People call all the time. I feel this. What's going on? And we'll get you in, take a look, and you sort of allay your fears, or be able to give you some information that will help you be able to take care of it and treat it early enough. But yeah, these early signs: bleeding, swelling, bad taste. You want to get that looked at.
Yeah, that's great advice. And if you're experiencing any of those symptoms and want to get a hold of Dr. Singletary, check out the links in the show notes. Be sure to subscribe to the Gum Guru podcast so that you can be informed when new episodes come out. This is always great information to have so that you can be aware of what's going on in your mouth and the actions that you can take to protect yourself and keep yourself healthy. So we'd love to hear from you as well. Be sure to follow us on all the social media accounts. Again, you'll see those in the show notes, but that's going to do it for this episode of The Gum Guru. On behalf of Dr. Macon Singletary, I'm Jason Kong. Thank you so much for listening and watching.
Thanks for watching. Be sure to like and subscribe so you don't miss more tips to keep your mouth healthy. Learn more by visiting NorthRaleighPerio.com.